Hello, I'm Dong-Hyun Young from Asan Medical Center, Seoul, Korea. Welcome to the Listen to Author of KJR. I'm pleased to present my article entitled Fully Automatic Coronary Calcium Score Software Empowered by AI Technology, Validation Study using 3 CT Cohorts. The first author, Jung-Goo Lee, holds stock in Cohorts Software, a medical software company of Korea, and Jung-Goo Lee and I had a contract of technology transfer with that company. This is the first paper had introduced the CAC by Augustin and his radiology colleague Yanovich in 1990. More than 30 years after being introduced, CAC scoring still requires manual operation by skilled professionals and the associated processing time. We developed an automatic CAC program by performing segmentation of cardiac structures such as coronary artery and ventricles on non-contrast enhanced CT scan. This study aimed to validate this program using a previously published cardiac CT cohorts from my institution. We developed this software using 100 CT angiography dataset matched with CAC images. This dataset was randomly chosen from previous paper, coronary artery-based myocardial segmentation datasets. Let me explain how we developed this program. First, we labeled the coronary artery and non-coronary regions on CT angiography of our development dataset. Second, we transferred the spatial information from CT angiography data to non-enhanced CAC images by image registration. After that, we could obtain the labeled dataset to train the semantic segmentation of the non-contrast CAC images. Using deep learning for semantic segmentation of the CAC image, we can get spatial information from the non-enhanced CAC image. This is the basic algorithm of our software, CAC Auto. This is the Atlas-based automatic CAC we developed. Because we know the spatial information even on non-enhanced CT, we could discriminate coronary calcification from non-coronary calcification to coronary calcification. Moreover, we could classify coronary calcification into left main, left anterior descending artery, RCA, and circumflex artery. To validate this program, we made a validation dataset from 3 CT cohorts previously published after ILB approval. The validation dataset includes asymptomatic patients, symptomatic patients, and patients with valvular heart disease. Finally, approximately 3,000 patients were enrolled, covering 4 types of CT machines from 2 CT vendors. For reference standard, manual calcium labeling was performed for all patients. The labeled mask containing binary information of calcium or not was saved for the per-lesion analysis. We calculated per-lesion sensitivity and false positive error ratio. We reviewed all mismatched regions between AI and human. The Gaston score and volumes reliability was evaluated using Intraclass Correlation coefficient, blend Altman analysis, and Kappa statistics. Here are the results of this study. The CAC Auto showed a very high ICC value of 0.9090 for all cohorts. In the per-Basel evaluation, this high ICC was maintained over 0.9. Take a look at this scatter plot, which has a log-scaled x and y-axis. We can see a very nice correlation between the two measurements. These colored areas mean risk categories of the calcium score. The limits of agreement of the Gaston score was only 1.6. Although there were some outliers, no systemic deviation did not occur in our program. This table summarizes the cardiovascular risk assignments by the CAC Auto. The overall accuracy was 94%, and only 0.7% of subjects had more than 2 categories differences between AI and human. We identified about 6,000 calcium lesions in this study. In the per-lesion evaluation, the false positive rate was 0.1 per patient. That means there was only one false positive classification per 10 patients. The most common false positive error was image noise or motion artifact, followed by aortic wall and pericardium. Of interest, there was some human error. After excluded image noise, the anatomically false positive error was only 0.06 per patient. This value is quite low as compared with previous works, which will be introduced later. Here are examples of the false positive calcium regions on CAC scan. Image noise and calcification in the aortic wall, pericardium, and so on. Sometimes a human may miss a small coronary calcium counted as a false positive lesion of AI. This study proved that the CAC auto showed very reliable results of automatic CAC with low false positive error and high correlation as compared with manually labeled coronary calcium. This is a comparison table between this current study and previous works. ICC and false positive rates was quite good in this study as compared with studies previously published. Nonetheless, we need more works on algorithm improvement to reduce some outliers. A further study to show the actual CAC imaging workflow could be streamlined by the AI software is also warranted. In conclusion, the Atlas-based CAC auto software empowered by artificial intelligence provided reliable calcium score measurement and risk category classification, which could streamline CAC imaging workflows. Thank you for your attention.